CPR providers should give rescue breaths with an inflation duration of around 1 second and provide sufficient volume to make the patient's chest rise. Breathe gently and steadily, avoiding rapid or forceful breaths. The maximum time taken between compressions to provide 2 breaths should not exceed 10 seconds. If the breath doesn't go in, check for obstructions in the mouth, but do not do blind finger sweeps. Reopen the airway and try again, but only try the recommended number of times. For example, don't try 6 times to get 2 breaths in. We can deliver the breaths via mouth, but also in other ways. Mouth-to-nose ventilations is an acceptable alternative to mouth-to-mouth ventilations. It may be considered if the patient's mouth is seriously injured or cannot be opened. The CPR provider is assisting a victim in the water, or a mouth-to-mouth seal is difficult to achieve. Mouth-to-tracheostomy ventilations may be used for a patient with a tracheostomy tube or tracheostoma who requires rescue breathing. Barrier devices such as face shields and pocket masks decrease transmission of bacteria during rescue breathing in controlled laboratory settings. Their effectiveness in clinical practice is unknown. Bag valve masks provide an effective way of delivering breaths to a patient without any risk of mouth-to-mouth contact, but they do require extra training and practice to ensure they're used effectively. The Resuscitation Council have carefully considered the balance between potential benefits and harm from compression-only CPR compared to standard CPR that includes breaths. As a result, they've recommended that individuals who have been trained to deliver CPR should, wherever possible, perform rescue breaths and compressions, and this may provide an additional benefit to patients, particularly for children and those who have sustained asphyxial cardiac arrest, for example, drowning, and where the EMS could be delayed. Only if rescuers are unable to give rescue breaths should they deliver compression-only CPR.